Hello, I am Dr. Ahilasamy from Chennai. I am going to show a case of left chronic fungal maxillary sinusitis. Managing the bleeding situations or a bloody area under local anesthesia. This is a coronal CT scan images showing the left maxillary opacity and anti-rhythmod also opaque. But the disease is mainly confined to the left maxillary sinus, and in the zoomed picture you can see the heterodense opacity suggesting it's a fungal maxillary sinusitis or fungal granuloma. This is an axial cut again showing the heterodensity and hyperindense areas also. This is a sagittal picture showing the same picture. I am taking the case under local anesthesia. This is a 40-year-old male patient. You can see a swollen uncinate looking like a middle terminate, and there is pus dripping from that. This is a diagnostic endoscopy. The right side is normal and everything. This patient has been taken under local anesthesia with a moderate IV sedation. Hardly any working area, so and a big spur in the floor. So we cannot give a sphenopalatine block in this case. First, I am packing the nasal cavity and the middle meatus repeatedly with the roller gauze soaked in 4% lignocaine and adrenaline in the ratio of 1:1, that is 10 ambule or 10 ml of adrenaline and 10 ml of 4% lignocaine. Since we cannot give a block inside the nose because of spur and edematous inferior terminate and we couldn't see the middle terminate, I am going for the greater palatal block, which I am palpating the hot palate posterior edge and 6 millimeters anteriorly between the gingival margin and the midline. I am palpating the foramen and giving with a spinal needle 23 gauge bent to for 2 centimeters, and the 2 centimeters has to go in. And I will be giving a solution of 0.5% ropivacaine and adrenaline 15 drops in 20 ml. So it will be 1:50,000 adrenaline. With this only block, I am operating the surgery in this case because we couldn't give any sphenopalatine block. If you are not confident in giving a good greater palatal block, you cannot do the surgery under local anesthesia. Now I am using my own design, Dr. Ahila's uncinate dissector, to dissect the uncinate process. Because it is a very inflamed case, it is bleeding a bit more than the usual local cases, but definitely lesser than the GA cases. Please watch these videos in a big screen on a TV monitor or a laptop, or pair your mobile to a big TV screen and watch to appreciate the quality. The uncinate dissector, he could very well dissect. Hardly the middle terminate is not visible so far, and the patient is very comfortable. Since because of lot of inflammation, it's little bleeding. Even though I have treated the patient preoperatively for 5 days with itraconazole and prednisolone. Itraconazole 100 milligram twice a day and prednisolone 10 mg twice a day. Now I am using the scissors to cut the dissected uncinate process superior end and the lower part. And I will remove the uncinate in toto with the Blackesley forceps. Now once this uncinate is removed, you can see fungal material in the hiatus semilunaris, that is between the uncinate and the bulla. It's a maxillary fungus which has come into the hiatus semilunaris and into the middle meatus. This fungal material will be taken out and will be sent for histopathological and microbiological analysis like evo staining and fungal culture. Keep sucking, never allow the blood to trickle down. See, the maxillary sinus fungus has melted because of the itraconazole and prednisolone given preoperatively. So it is very suckable like a butter. These edematous tissues are being shaven off. Even though the spur is there, I'm not going to remove it. Since it's a little bloody, I'm just repeatedly packing that area with a roller gauze soaked in that same 4% lichenocaine adrenaline to get a better field area. So when the field is little bit bloody or bleeding, you repeatedly pack the area with the roller gauze soaked in 4% lichenocaine and adrenaline. Now I am using the shaver to take off the edematous tissues to make the middle meatal androstomy opening wide. So far I am using only the 0° 4 mm telescope. Now I am taking the polypodal bulla also. That means I am doing the anti-ethmoidectomy. There is some gush of bleeding while I am doing the anti-ethmoidectomy. Just keep troubling me throughout the surgery. You can watch little later how I manage that bleeder. See, the melted butter like fungal material is coming into this section of the debrided. I am again repeatedly packing the area to get a good field. Again, I am using the shaver. Small trickle of blood I will be asking the patient to swallow. Again, the fungal material which is semi-solid or butter-like is being sucked out. Cheesy you can call it. So always use, if you know that it is a fungal, preoperatively itraconazole and prednisolone for 5 days to 2 weeks preoperatively. It makes your job easy. Now all the fungal material sucked out. There's a thin coating of secretions which will come out with the ciliary movement, but still I am using the wet mopping technique. Now I have come to the 70° telescope and I will put the roller gauze inside the thing and roll it, wipe it and take it out and all the secretions out. Do it once or twice. Again I am doing for the second time to make it. It's a 30 minutes video edited to around 10 minutes. Still the field is little bloody like, but lesser than the GA field, unlike the typical local field because of lot of inflammation. All those roller gauze will be wiped and taken out. I can using the malleable ring also to mop it off and take out. Sinuses still some, once more I clean and it will be done. Now it's clear, but there is some blood trickling from the anti-ethmoids. You can see the blood trickling from the anti-ethmoids. A small vessel. See, a small vessel is there because of inflammation. There's a proliferation of the vessel. Don't go for cautery. You can just pack it with an same roller gauze soaked in adrenaline and 4% in the ratio 1:1, and I will stop it. If it doesn't stop, then only cautery. Most of the bleeding within the nasal cavity will stop with the good packing of roller gauze soaked in 4% and adrenaline, 4% xylocaine and adrenaline, and keep it pressed for a couple of minutes. Then take it out, the bleeder will stop. Even a spinopolitan bleeder will stop. The bleeder has stopped. We don't pack the nasal cavity after surgery for all nose and sinus surgeries, and they discharge the patient same day evening as daycare. Very good field. Patient is very cooperative, no bleeding. Thank you for watching. You can contact me at the above address anytime. Thank you. See you in another beautiful video.